Bismillahirrahmanirrahim. This video is about atelectasis and following are references for this video. Atelectasis or collapse of the lung is incomplete expansion of the lung as happens in neonates, and it is collapse of previously inflated lung, and this results in areas of poorly aerated pulmonary parenchyma. So two results of this atelectasis or collapse of the lung tissue are reduced oxygenation, and also this collapse predisposes the area to infection. The three types of atelectasis are resorption atelectasis, compression atelectasis, and contraction atelectasis. The resorption atelectasis and compression atelectasis are reversible, while this contraction atelectasis is irreversible type because it is associated with fibrosis. So the collapse of the alveoli can be localized or complete, and the common causes of this collapse are total obstruction of the airway or lack of the surfactant in the fluid lining the alveoli. The atelectasis that is due to airway obstruction can occur in a small bronchi due to presence of a mucus, or in a large bronchus due to presence of a tumor or mucus plug. The air is entrapped in the area distal to the blockage, and this within hours or minutes it will be reabsorbed by the blood that is flowing in the capillaries. If the lung tissue is pliable enough, it will suddenly collapse. But if the lung tissue is rigid due to presence of fibrosis, there is development of negative pressure within the alveoli, and this negative pressure within the alveoli will suck the edema fluid from the capillaries, and the alveoli fill completely with the edema fluid. Now, what are the effects of this atelectasis on overall pulmonary function? The lung collapse will result in alveolar occlusion, as well as there is increased blood flow resistance in the pulmonary vessels. Partly, the alveolar occlusion will lead to decreased lung volume, and this decreased lung volume will compress, and there is folding of the vessels that will cause the increased blood flow resistance in the pulmonary vessels. The collapse of the lung leads to the hypoxia in the tissue, and local hypoxia will lead to the vasoconstriction, and this vasoconstriction uh, lead to the uh, increased blood flow resistance in the pulmonary vessel, and most blood now route to the ventilated lung if one whole lung is atelected or is collapsed. So the this blood that is diverted is now aerated blood. As a result, 5/6 uh, of the blood is aerated, while only 1/6 of the blood goes to the collapsed lung. So the ventilation perfusion ratio is only moderately affected, and despite the collapse of the whole lung, there is mild aortic oxygen desaturation. This diagram is showing the effect of atelectasis on aortic blood oxygenation, and here you can see that the pulmonary arterial blood oxygen saturation is 60%, while in the collapsed lung this saturation is 60%, and here the flow is 1/5 of the normal, while the uh, most of the blood is now diverted to the right side that has got 97% saturation, and the mean of these 5/6 uh, of the well oxygenated blood, that is 97%, and 1/6 of this 60% will give a mean saturation of 91%. Another cause of development of atelectasis is due to lack of surfactant. Surfactant is secreted by special alveolar epithelial cells, and it coats inside of the surface of the alveoli, and it is responsible to decrease the alveolar surface tension 2 to 10 times, and hence it prevents collapse of the alveoli. This surfactant is deficient in hyaline membrane disease, that is also termed as respiratory distress syndrome in newborn babies, and due to decrease or absence of the surfactant, the uh, prevention of the collapse is lost, and the surfactant uh, loss and the surfactant protective mechanism is lost, so the surface tension is increased, and it will lead to suffocation, and if the large area of the lung is affected, it will result in death. Now with this background knowledge, we revert to our first slide where we described the atelectasis as incomplete expansion of the lung or collapse of the previously inflated lung. That resulted in reduced oxygenation and predisposed the area to the infection. There are three types: resorption atelectasis, compression atelectasis, and contraction atelectasis. Among these, the resorption and compression type are reversible, while the contraction type is irreversible because it is associated with fibrosis. The primary atelectasis is also termed as neonatal atelectasis, and it is defined as incomplete expansion of a lung or part of a lung. It is seen in stillborn infants as total atelectasis in the form of total atelectasis, or in premature infant it is seen as a result of weak respiratory action that develop incomplete expansion of the lung and clinical atelectasis. The causes are prematurity, cerebral birth injury, CNS malformation, and intrauterine hypoxia. Grossly, the lungs are small, dark blue, fleshy, and non-crepitant, while histologically it is characterized by alveolar spaces in the affected area that are small, and there is thick interalveolar septa, and it contains proteinaceous fluid with a few epithelial squames and meconium. There are scattered aerated areas of the lung that are hyperinflated that cause interstitial emphysema and pneumothorax. The resorption atelectasis results from obstruction of an airway, and this obstruction may be the result of excessive secretion by a mucus plug, or due to presence of exudate within the smaller bronchi, such as bronchial asthma, chronic bronchitis, or bronchiectasis. With the passage of the time, there is air resorption in the distal area, and it will lead to the collapse of the distal lung, and this collapse will result in decreased volume, and as a result, when volume is decreased, there is mediastinal shift toward the affected lung. The compression atelectasis results from accumulation within the pleural cavity. There can be presence of fluid in the form of transudate, exudate, or blood. There may be presence of a tumor or presence of air, that is pneumothorax, in the pleural cavity that will result in the collapse of the lung tissue, and there will be a mediastinal shift that is away from the affected lung. The right middle lobe syndrome is a syndrome that is the atelectasis due to obstruction of the bronchus to the right middle lobe, usually from external compression by a hilar lymph node. The, the middle bronchus is usually susceptible because it is long and slender, and it is surrounded by lymph nodes. On histologically, the lungs show bronchiectasis, chronic bronchitis, bronchiolitis, lymphoid hyperplasia, abscess formation, and dense fibrosis. There may be presence of acute and organizing pneumonia or the evidence of tuberculous lymphadenitis or metastatic lung cancer. The third variety, the contraction atelectasis, is due to focal or generalized pulmonary or pleural fibrosis that prevents full pulmonary expansion, and this is responsible for collapse of the lung. So this is the gross appearance of the lung. The right lung here in this infant is pale and expanded, while the left lung is collapsed or atelectatic. This is another gross picture of the lung at autopsy. It is showing that the right lung is collapsed, and this white arrow is pointing towards the blood that is accumulated within this pleural cavity, and this is hemothorax. So here is the radiological appearance of atelectasis. In this chest radiograph, there is expansion of the right chest cavity due to pneumothorax, and there is also displacement of the heart to the left. So this is the CT image of atelectasis. There is presence of bilateral pleural effusion that is marked here, and also there is bilateral atelectasis of the lower lobe. The right atrium is hypertrophied. There is enlargement of the right atrium. It is due to rheumatic mitral stenosis with chronic pulmonary congestion and subsequent pulmonary hypertension. Thank you very much.